All right, so we're going to be talking about the clinical utility of artificial intelligence-based review of echocardiography for diagnosis of cardiac amyloidosis. My only disclosures are consultant. I've been a consultant for Alnylam as well as Ultromics. So let's start first by speaking about the populations at risk. When we read echocardiograms in cardiology, usually we're not just looking at the imaging study completely in isolation. We want to know what the ordering provider was interested in examining the patient for. And so a lot of times, they may not be thinking about rare diseases like amyloidosis, but they'll say that, the patient's short of breath or the patient's having chest pain. When the reason for the study is heart failure with preserved ejection fraction or aortic stenosis, these two very common diagnoses in cardiology um, are now known to be caused, in some cases, due to amyloid infiltration of the heart. So the prevalence rate of amyloidosis in patients with heart failure with preserved EF, as well as aortic stenosis, is approximately 15%. Um, in various studies that have been published. Usually, the subtype of the amyloid infiltration within the heart is transthyretin. So, in these two populations, it's usually ATTR that is causing these conditions to occur. So, when we see an echocardiogram come across with these particular reasons for the study being ordered, um, while we are, of course, trying to elucidate on the severity of the heart failure or the severity of the aortic stenosis, and the filling pressures and how much trouble the patient may be in clinically so that the patient can be managed appropriately. Meanwhile, in the background, we're also thinking about why these patients have these conditions. Heart failure can be due to a variety of reasons, but again, in 15% of cases, we now have an understanding that this could be due to ATTR. With multiple myeloma, as well as other monoclonal gammopathies, we find that about 10 to 15% of those patients end up developing AL amyloidosis. So this is called light chain amyloidosis. It's a different form, while ATTR is a consequence of an abnormal protein being formed in the liver. Transthyretin is a liver-based protein that misfolds and forms amyloid fibrils. When it comes to light chain amyloidosis, these light chains are a consequence of overproduction from the bone marrow. So the disease is originating in a different location. So when patients have multiple myeloma and they have an echocardiogram ordered for whatever the reason may be, we're examining these echocardiograms very closely to look for potential light chain amyloidosis that we might be able to pick up within the heart. So if you take a look at an echocardiogram, this is essentially what we are looking for. Just so you can see what a normal study looks like. Um, you can see here, this is the left ventricle, this is the mitral valve, this is the left atrium, this is the aortic valve, and this chamber here is the right ventricle. So this is called a parasternal long axis view. So we are examining the heart just right next, it's just to the left of the sternum, and looking at it in long axis. So as you slice the heart in this direction, you can see the septal wall and the posterior wall, and you can see what the relative thickness of these walls should be. Now, when you look at this image on the right, this is a patient who has cardiac amyloidosis. As you can see, these walls, the septal wall and the posterior wall, are now much thicker, very dense, and very bright in appearance. This sparkling, dense appearance is pretty common in patients who have infiltrative heart disease, specifically amyloidosis. What you also see is there's a dark space behind the heart. This is a small pericardial effusion. So due to the amyloid infiltration, there is inflammation around the heart. That inflammation can give rise to a small amount of fluid that you can see around the heart. What you may also notice, as opposed to the normal heart on the left side, is that this mitral valve looks a little bit thicker and appears to be a little bit restricted in its motion. So amyloid can also, of course, deposit within valvular tissue. Um, so these are the basic sort of differences, and this is the way we look for amyloidosis on an echocardiogram. We're very closely examining the wall thickness and the valves and the overall pressures. I'm not going to talk about diastolic function too much because that's a fairly advanced topic for this audience, but one thing that I will point out is a novel parameter that we look at, apart from just ejection fraction, which is the squeeze function of the heart. We're looking at the longitudinal motion of the ventricle. This is a technique called global longitudinal strain. We basically outline the endocardium, and then the software will track the specular movement of the tissue in the longitudinal direction. So from base towards apex, we look at how well the tissue moves. The myocardium should contract and move towards the apex by approximately 20%. So we want to see shortening of the ventricle by 20%. So this speckle here should move this way. But if you look at this image, you can see that if I put my pointer right here on the annulus of the mitral valve on the septal side, the tissue barely leaves that laser pointer. So it's really not moving longitudinally very, very well. So instead of 20%, the global longitudinal strain in this case is negative 10%. So it's about half of what it should be. So in a case of cardiac amyloid, you will see this kind of dysfunction. But what is pathognomonic for cardiac amyloid is that the dysfunction will spare the apex. So the very tip of the heart will be spared. As you can see here in this bullseye plot, you see relatively normal values at the very, very apex of the heart, while the remainder of the heart looks abnormal. The clinical challenge with diagnosing this disease is that we usually pick it up very late. The clinical signs are very nonspecific. So patients might complain of some shortness of breath, or they've got tingling in their feet, or mild amounts of swelling. These are very nonspecific symptoms, and they can be caused by a variety of conditions. In the echo lab, cardiologists tend to pride themselves on catching the disease early, but honestly, the reality is that we are still picking it up very late because it takes a fair amount of cardiac amyloid sort of advancement. The amyloid fibrils have to deposit for years in order to produce the pictures I just showed you. To get the heart to that point, the disease has advanced quite a bit. When it comes to more subtle cases where there might just be a little bit of thickening of the heart, that can often get dismissed because maybe there are other things that can cause thickening of the heart. The heart can be thick because you have high blood pressure, so it's working too hard and it will thicken like any muscle. Moreover, in busy clinical practices where they're reporting high volumes of echocardiograms, more subtle signs can really get missed. Like I showed you, global longitudinal strain is a novel parameter that can be very helpful in diagnosing amyloidosis, but it's not universally utilized. And even simple measures such as measuring wall thickness can be challenging because how we measure, the techniques of how I measure it versus how someone else measures it, where a sonographer may place the calipers for measurement can be different. And that variability can give rise to underdiagnosis and underrecognition. So subtle findings can often get overlooked, even more so when the ejection fraction is normal. So most of the time, these patients have normal internal squeeze. It's just that longitudinal motion is impaired. But that internal squeeze, which is what most people are looking at, that can often be preserved. So at my institution, at City of Hope in Los Angeles County, we've taken a few different measures to try to identify these patients in a more systematic fashion. One of the earlier projects we worked on was to institute an algorithm within our electronic medical record to identify patients with moderate amounts of wall thickening. So we thought that this would be fairly straightforward. We're going to program the EMR to give us a list of every patient that's been scanned that has a wall thickness of 1.4 centimeters or greater, because that's considered moderately thickened. So we're going to avoid maybe mild thickness, but we wanted moderate or severe thickness to be picked up. This generated a list of hundreds of patients, and then I had to personally go through hundreds of these echocardiograms to determine whether I agreed that there was indeed moderate LV wall thickening or not. And the reality was that it was only a fraction of these patients that truly had left ventricular wall thickening. We did then contact those suspect patients to initiate an evaluation if they didn't already have a known diagnosis. So this was a quality improvement project, and what we found from it was that the overall effort, though, involved in finding these patients was relatively high because of the amount of human manpower that was required to review these studies. So we then moved on to trying to assess if there were other novel echocardiographic measures that we could use that would be better at picking up the disease early. So again, we don't need it for those patients who are presenting with late stage disease where you see significant wall thickening. I think what we want is to pick them up earlier so that we can make an intervention at an earlier point and prolong their overall survival. So we looked at, I talked about longitudinal strain of the ventricle, but amyloid is a disease that is systemic. And our hypothesis was that it deposits in not just the left ventricle, but also in the right ventricle, and the left atrium, and the right atrium. Really, the entire heart is probably dysfunctional if you look at it in detail. And so we decided, well, the left atrium is a nice thin chamber. It probably takes only a little bit of amyloid deposition to make it dysfunctional. So let's look at the function of the left atrium. So we studied 150 patients, 50 with known cardiac amyloidosis, 50 with light chain amyloidosis without cardiac involvement, and 50 with multiple myeloma as a control group that still had a monoclonal gammopathy. I'm not going to go through all of the results in detail, but what I will say is, so these are all the parameters that were statistically significantly different in the group that has cardiac amyloidosis known by tissue biopsy. So what I can tell you is if you look at left atrial strain, these values are like less than half, sometimes a third of patients who don't have cardiac involvement. So very, very statistically different values showing that left atrial strain can be a powerful imaging marker of cardiac amyloidosis. These other echo parameters are also quite different in the cardiac amyloid group. But overall, what these projects have demonstrated is that it takes a lot of effort to diagnose the disease, even on an echocardiogram. And clinicians have to study multiple echo parameters to ascertain the suspicion. The methodology has to be consistent, and ultimately the diagnosis remains complex, time-consuming, and very challenging in busy practice settings. So this is where artificial intelligence comes in and can really solve these challenges as a single solution to all of these issues. Um, we are working with a vendor that is looking at one view of the heart, and in that one view where all four chambers are visible, the artificial intelligence algorithm has been trained to identify cardiac amyloidosis in comparison to normals. And what it's doing is it's essentially watching the speckles and watching all that movement. And in doing so, it basically sees the things that we were measuring. So we were measuring global longitudinal strain, that longitudinal movement from base to apex. It doesn't need to measure that using Doppler or using anything other than its own algorithm. It's basically seeing that longitudinal movement. It's also seeing the left atrial movement. It's seeing the right ventricular movement. It can see the wall thickness. It can assess for effusions. And even, there are diastolic parameters that are used to determine diastolic dysfunction. We use different entities to measure velocities of tissue as well as mitral inflow of blood. And all of that is done using Doppler, but essentially an algorithm can watch the tissue and measure those things without traditional measurement techniques. So in utilization of machine learning, this ends up reducing a lot of human effort, and imaging review becomes systematic and consistent. So, in terms of the way that we first started working with an AI vendor, it was really not specifically with a focus for cardiac amyloid. My interest was to reduce inter-reader variability and maximize reproducibility of our reports as an echo lab within a cancer center. So within the practice of cardio-oncology, hematologists and oncologists will routinely order echocardiograms to measure the health of a heart. They want to know what the strength of the heart is to ensure that patients can undergo chemotherapy or undergo bone marrow transplantation, for example. For a variety of reasons, it is very important that we measure the function of the heart accurately and reproducibly. But the problem is human readers tend to vary in our reports of systolic function. How well the heart squeezes, we might be, even some people will report ejection fraction visually, so just based on impression. In our lab, we certainly actually do calculate it by defining the endocardial border of the heart in diastole and then comparing it to systole and then coming up with a calculated value for ejection fraction. However, where we place our endocardial border can differ between readers. Published studies have demonstrated that across good echo labs, there can still be a variation of 10% in ejection fraction. And that's a huge problem in cardio-oncology because the definition of cardiotoxicity is a drop in EF of 10%. So obviously in our lab, we can't tolerate what is tolerated in the community of a 10% variability in ejection fraction. So my initial interest in artificial intelligence was to minimize that variability. So we reached out to this company called Ultromics because they were at the forefront of measuring ejection fraction. They later pivoted from measurements into actual disease identification. And I think that this is where AI becomes very interesting and exciting because it's doing more than just rote measurements. Okay, so it goes beyond that, and now it's trying to diagnose disease by pattern recognition and training over thousands and thousands of studies. And their initial algorithm was developed to identify heart failure. And then this year, they gained FDA approval to identify cardiac amyloidosis. So we worked with our IT department and the vendor to set up echo data anonymization because we were going to have to send the pictures to their cloud-based platform. And obviously, we couldn't send patient data with it. And so we had to anonymize that. And then the report was sent back into our echo lab so that we could act on that. So we trained our cardiologists to incorporate these findings into our clinical reports. And at this point, every echo that we run at City of Hope is analyzed by AI for HFpEF and cardiac amyloidosis. I'm not going to go through the implementation steps as that may not be relevant to this group. But I will go over the number of studies. So in terms of our overall experience, we've got about 1 year of experience now looking for heart failure in these cases. And so we have a positivity rate of about 9%. So 9% of our patients, if you look at close to 8,000 echoes that have been reviewed, about 9% of them were positive for heart failure. And then within that group, over the past 6 months, we've been running them through the secondary profiler for looking for amyloid. And so of the heart failure positive cases, which was 346, 15 of those were positive for amyloidosis. So we're seeing a positivity rate of about 5% in our HFpEF population. It's probably lower than the 15% prevalence rate in the general community because this is a cancer population and their heart failure is often a consequence not of true intrinsic heart disease, but rather volume overload from infusions that are part of delivery of chemotherapy and stem cell rescue. So our workflow has changed a bit since we added artificial intelligence into our echo lab. We used to look at multiple risk factors, and there was always a lack of clarity regarding which patients should be referred for formal evaluation. But now we have this one additional major risk factor, which is a positive report of amyloid from the AI profiler. And when we see these positives, like the 15 cases I showed you, 10 of, we review them to see how many of them have a known diagnosis. So in that cohort of 15 patients over the past 6 months, 10 of them had a known diagnosis, so we didn't need to take any actions on those. But 5 were patients who were not known to have amyloidosis. 1 patient had already passed away, but 4 were living, and we've referred them for evaluation to our amyloid clinic. So, so the hope is that we will be able to detect the disease earlier than it really is presenting and make a difference in these people's lives. I'm going to go over one case just to illustrate the overall utility of this tool. So this was a 78-year-old male with multiple myeloma who was referred to me for tachycardia. Um, Being a cardiologist, the first thing I did was order an echo. And as I showed you in some of the initial slides, I'm very interested in seeing what the wall thickness is because the patient has myeloma. Because he has myeloma, I'm worried that, well, he's got myeloma, they're sending him to me for tachycardia. Let's look for amyloid, make sure there's no heart disease here. So when I looked at his left ventricle, measured it in multiple locations, and I'm really not seeing significant thickening of this man's left ventricle. His valvular function looks good. The mitral valve is fine. The aortic valve is fine. There's no effusion. We're not really seeing any signs of cardiac amyloid on this image. This is a four-chamber view of the heart. This is the left ventricle. Again, it squeezes quite well. This is a normal ejection fraction of over 60%. The only thing that maybe I could say about this is maybe the atria look a little generous in size, but nothing too significant. So now we'll move on to measuring global longitudinal strain. The ejection fraction is normal, but let's look at the longitudinal movement of this heart. And what we end up finding is on the global longitudinal strain, we see a relatively low normal value of negative 15.7%. And so normal is defined at, negative 18%, but negative 15 to negative 20 in some labs is considered normal. So from 15 to 17-ish, I feel like it's borderline, negative 18% to or better. So moving in the more negative direction. So negative 18 towards onward to 20 and beyond is quite good longitudinal movement. So this is sort of a kind of a borderline lowish normal value. So nothing that I would take too seriously. I feel like this is okay. Now, one thing that is interesting here is when you look at the bullseye plot, the values are higher at the apex than they are in the mid-ventricle or the basal segments. So that concerned me a little bit. So again, this patient has myeloma, and now we're seeing this apical sparing pattern a little bit. So I've got some concern. This is the man's diastolic function, which we would have graded as grade 2 diastolic dysfunction. So there is some stiffening of the heart. This is the right ventricle. The right ventricle is normal in size and function, but the pressures in the right ventricle are mildly elevated. So in this case, given that the man has multiple myeloma, he's got some diastolic dysfunction, he's got a little bit of apical sparing, and then the right-sided pressures are a little high. I have concern, and I don't want to dismiss this as a patient who wouldn't have amyloid. I think there's a possibility there's amyloid, but it's just strange that the ventricle is not thickened at all. So the wall thicknesses are normal. There's no sparkling myocardium the way you would see in cardiac amyloid. So I went ahead and measured this experimental measure, which I shared with you earlier, which is called left atrial strain. So I looked at the function of the left atrium, and that was markedly reduced. So given that this was markedly reduced, I had enough suspicion that I wanted to do something more. I wasn't ready to biopsy the heart. I didn't feel like an invasive test was warranted off of something experimental. So I went to an intermediate sort of diagnostic choice, which is cardiac MRI. So the cardiac MRI demonstrated late gadolinium enhancement in the left ventricle as well as in the atrial walls. So this was consistent with cardiac amyloid. So based on that, most likely, given the history of multiple myeloma, this man probably has AL amyloid with cardiac involvement. That's what we can say based on this cardiac MRI result. In order to treat him for that, we have to demonstrate this on tissue. So we went ahead and wanted to be as least invasive as possible. So we first examined his bone marrow because we had that from the myeloma diagnosis. So the bone marrow was first stained with Congo red, but that was negative for amyloid. So we then moved on to a fat pad biopsy, which is relatively not too invasive, and that was unfortunately negative for amyloid as well. But given that I was pretty convinced based on his imaging and the cardiac MRI, we then referred him for an endomyocardial biopsy, which came back positive. So we then sent the tissue for mass spectrometry, which confirmed that the type of amyloid was light chain. So this patient was then initiated on treatment for AL amyloidosis. This man then came back earlier this year for a repeat echocardiogram, except now he was in atrial fibrillation. So the heart rhythm is now abnormal. The atria is no longer contracting. The atria are now fibrillating. Okay. So this changes the clinical situation a little bit. It also changes the way the pictures look. So the walls remain thin, even though a year and a half has gone by. The walls of the heart remain thin. And what I was thinking to myself was, well, what if this patient had not been diagnosed last year and he just presented now for this echo, and I knew that he had myeloma? What would I think if I just saw this echo? So I would look at the walls. The walls look thin. There's no effusion. The valves look fine. I would then move on to the four-chamber view, which looks fine. The ejection fraction is normal. I would then measure global longitudinal strain. Global longitudinal strain is actually higher than it was on the last echo. It's basically normal at negative 17%. That apical sparing, I mean, this is all over the place. I can't make much of this, and the overall value is normal, so strain doesn't tell me much here. Um, Diastolic function cannot be assessed in patients who have atrial fibrillation, so we have no ability to detect anything wrong with diastology here. When I look at his right ventricular pressure, which was elevated on the last study, it is now normal on this study in atrial fibrillation. I also am unable to measure left atrial strain because the patient's in atrial fibrillation. So when the atria is fibrillating, it doesn't function well. So having a low left atrial strain value is not going to be of any specificity, right? It's completely useless at this point. So now all these things that I thought were abnormal on the previous echo are masked by AFib. So if this patient had not been diagnosed last year and come to us this year, we would have said that this is pretty much a normal echo for someone who has AFib. Though the walls are not thick, the global longitudinal strain is normal, right heart pressures are normal, and that's all we can say. So we probably, if they don't have symptoms of amyloidosis, we're not going to pursue the diagnosis in this case. However, at this point, we had begun kind of using this AI profiler, and at the end of the echo, it gave me this slide, which told me that this patient has heart failure with preserved ejection fraction, and their probability score was 100%. So this patient is on the far right of patients. Basically, it will categorize patients based upon other echoes it has looked at. And echoes that are 100% likely to have heart failure, that's where this echo falls. It falls into this bin. And so now this is giving me some interesting information. It's saying that this patient has heart failure. And then the next slide it gives me is it says echo is also suggestive of cardiac amyloid. So even though I couldn't detect cardiac amyloid on this echo because of the AFib, the algorithm was still able to figure it out. And so if we had seen this and we didn't know about it, we would have then proceeded to further evaluation. Most likely we would have submitted this patient for a cardiac MRI. So what has happened in our lab is we are now seeing more referrals from divisional colleagues for suspected cardiac amyloidosis as a consequence of AI analysis rather than the reader himself or herself seeing findings that are concerning. So that's something new. And then we are also running a quarterly report of all positive cases and seeing if the patients have a known diagnosis. If they don't have a known diagnosis of amyloidosis, we then refer them to our clinic to evaluate for a monoclonal gammopathy, first looking for AL amyloidosis, and if that is negative, we then proceed to a technetium pyrophosphate scan to evaluate for ATTR. The overall impact of this technology is going to be fairly significant, in my opinion, and this is based upon the prevalence rates of amyloidosis in very common cardiac conditions. So heart failure is ubiquitous in the general population. Aortic stenosis is a well recognized disease of the elderly in the United States and across the world. And we're finding that 15–16% of these patients have ATTR. So there's a high volume of ATTR that remains under-recognized. And the problem is we don't know how to diagnose these patients. We're not going to subject all these people to biopsies. We're not going to do nuclear scans on everybody. Cardiac MRIs are burdensome exams that are also very high cost, and the availability is limited, expertise is limited, and so there is no easy way to just find them all. I think there is a general debate in the community as to how should be looking for this. And certainly, I think probably the most obvious uh, intervention is to ensure that the clinicians who are caring for these patients are looking for the red flag signs, right? So your patient has heart failure. Are we asking them about um, peripheral neuropathy? Like, is there any tingling in your hands or feet? Are you having any symptoms of carpal tunnel syndrome? Are there any other, history of spinal stenosis? So there's a lot of different red flags that need to be evaluated for. But that certainly places an additional burden on primary care physicians and primary providers. So where I think AI can really make a difference is running in the background in our echo labs, at least within the cardiology community, such that it's kind of overseeing every read and it's evaluating these cases of heart failure to see if there is underlying amyloid in that study. So if it can do that, which right now we're seeing sensitivity and specificity rates of approximately 90%, then this could really end up making a big difference in increasing the diagnosis and allowing for earlier medical intervention. As the technology advances, I think it's going to get better, and overall adoption of AI for these purposes will improve outcomes and survival. Thank you so much. Appreciate it.